Well, thank you everybody for joining today's webinar, Addressing the Critical Need for an Exclusive Human Milk Diet for Premature Infants. My name is Susan Hepworth. I'm the Executive Director of the National Coalition for Infant Health, and I'll be hosting today's webinar. After my brief introductions of our speakers, I will give a brief overview of a clinical proceedings, and then I will turn it over to our expert panelists to review the clinical proceeding white paper findings. We have saved some time at the end for question and answers, so please feel free to use the Q&A button at the bottom of your screen throughout today's presentation to submit your questions, and then we will have time to go through those at the end. A little bit about the National Coalition for Infant Health is a collaborative of professional, clinical, community, as well as family support organizations who are primarily focused on promoting patient-centered care for all infants as well as their families. So that includes infants that are born preterm and all the way to full-term healthy as well. I'm really pleased to be joined today by Dr. Dan Stewart, Professor of Pediatrics at the University of Louisville and neonatologist at Norton Children's Hospital. Also very pleased to be joined by Dr. Kate Tauber, a Professor of Pediatrics and neonatologist at Albany Medical Center. So what is a clinical proceeding? A clinical proceeding is an informational resource that is intended to raise awareness or address an unmet need that exists within infant health or issues that might impact their families as well. So this is actually the first ever clinical proceeding that the coalition has undertaken, and it is authored by expert panelists, usually 4 to 6 expert panelists. And as I mentioned, Dr. Tauber and Dr. Stewart served as expert panelists for this particular clinical proceeding. The outputs include a white paper, which you can see up there on your screen, as well as a webinar, just like we are hosting today, with 2 of the expert panelists who will review the top-line findings that were part of that clinical proceeding white paper. And really, these are intended to be written in a way where they are evidence-based, highly sourced, but written in a way that anybody who picks up a clinical proceeding can understand it. So that could be a healthcare provider, it could be a policymaker, it could be a parent or a patient advocate, to really understand from top to bottom what is the issue at hand, what are the barriers that might exist, and then what is the value of access. As I mentioned, this clinical proceeding had 4 expert panelists. So in addition to Dr. Tauber, who served as our chair, and Dr. Stewart, we also had Dr. Jenny Fox and Carly Austin, who were part of this expert panel. And with that, I'm going to turn it over to Dr. Stewart, who is going to review the first part of today's presentation.
Thank you for attending today's meeting, this critical information. And first thing, I'd like to introduce the concept of an exclusive human milk diet. So early nutrition and the development of a favorable microbiome really impacts both early and late morbidities and even mortality. So it's extremely important that early nutrition and the development of a favorable microbiome takes place in these babies. So as an introduction, so premature infants certainly face an increased risk of morbidity and mortality. So proper nutrition is essential for these babies. Exclusive human milk diet certainly improves feeding tolerance and reduces the risk of complications, as we will go through in this presentation. Barriers to access include awareness, insurance coverage, and lack of protocols. So what's the difference? Not all preterm infants are created equally, certainly. So you can both look at the birth weight as well as the gestational age. So if you look at birth weight, low birth weight is under 2,500 grams. A very low birth weight infant is under 1,500 grams or less. And then less than 1,000 grams is in extremely low birth weight babies. And certainly all these are an at-risk group for secondary morbidities. But you can also quantitate it according to gestational age. So a moderate to late preterm would be 32 to 37 weeks gestation. A very preterm, 28 weeks to less than 32 weeks. And then extremely low birth weight baby, or elegans, is considered less than 28 weeks. So this helps you categorize the babies who are at risk. So certainly all preterm infants are not created equal, but all require optimal nutrition to grow appropriately. Parental nutrition certainly has been our stalwart over the years, and it's formulated by healthcare providers. It's given intravenously through a dedicated central line, and certainly there are some risks of complications. We start early TPN in the first 24 hours of life in all babies who are VLBWs or ELBWs at our institution. Uh, Enteral nutrition is extremely important. It supplies the nutrients and the fluids given by mouth or the feeding tube. And obviously, the mother's own milk is critical if we can get that, or donor human milk and or fortifiers are certainly needed to meet the optimal growth requirements of these neonates. So not all premature infants are created equally, certainly, and our goal is to reduce the time to full feeds. So this is critical because then if we could get them to full feeds, we can remove the PICC line, so we decrease the risk of subsequent eclampsies or central line associated bloodstream infections. And a large study out of Japan of almost 14,000 infants showed that by using mother's own milk or donor milk and human-based milk fortifiers, that the babies reach full feeds much quicker. So what is an exclusive human milk diet? Well, certainly mother's own milk is optimal, and we certainly try to get our OB and our perinatalist to talk to mothers about providing mother's own milk. And certainly, in the first few days of life, we only get colostrum, but we do want to encourage the mother to start pumping after the birth of the baby. But if that's not available, or she chooses not to go that route, we can use donor human milk, which is donated by mothers to be used for infants that aren't their own. And this certainly fills a very need for neonatologists across the country and even across the world. And also human milk-based fortifiers. So these are commercially available products that can be added to human milk to meet the protein, the calories, and the micronutrients, as well as the macronutrients of these, particularly the extremely low birth weight babies, but also the very low birth weight babies. So it's extremely important that we utilize human milk-based fortifiers. I'll turn it over to Kate.
Thank you, Dr. Stewart. So I'm just going to talk a little bit about some of the benefits. So we know human milk is really important, and Dr. Stewart did a nice job sort of introducing us to some of the reasons. And he mentioned early on about the microbiome, which is extremely important to help a baby, preterm baby, develop a normal microbiome to be able to grow and develop and create an immune system that is healthy and protective. So a lot of the exclusive human milk diet literature and stuff in the press has been focused on necrotizing enterocolitis, which I know, as many of us who are neonatologists, that's sort of a very scary word to throw around. And certainly we have been working for decades to try to figure out what causes NEC in our preterm infants. And until the sort of idea that an exclusive human milk diet could reduce the risk of NEC in infants, this was sort of almost like a magic bullet or a silver bullet, because it really was the first time we were able to have some data that showed that giving these babies at risk, which are typically the very low birth weight and extremely low birth weight infants, something that could help reduce this terrible disease process. This was amazing. So most of the data has shown that it's a significant decrease in surgical neck, which is the most severe form of neck, but there is some data out there about decreasing all forms of neck. So it really is an important part of what we can do in the NICU to help prevent that complication. There's also some literature out there looking at reduced risk of severe BPD. And we know human milk has a lot of antioxidants, growth factors, bioactive factors, and things that can help reduce inflammation. And so certainly our, little tiny friends, less than a kilo, they are at high risk for BPD, given their potential long-term need for respiratory support. So giving them an exclusive human milk diet with factors that can help prevent some of that inflammation and worsening of lung disease is obviously very beneficial. Retinopathy of prematurity also has been shown to be reduced with an exclusive human milk diet. And again, I think a lot of that has to do with the antioxidant properties of human milk and to try to minimize some of the oxygen-free radical damage that the blood vessels can undergo when they're needing, when those babies are needing higher oxygen through ventilators. Late onset sepsis has also been shown to be reduced when you give babies exclusive human milk. And one of the really important things that we don't see right away in the NICU, but we do see out in the community, and for those that are involved in NICU follow-up clinics or even behavioral neurodevelopmental clinics or even primary care offices, is that babies who are given an exclusive human milk diet have improved neurodevelopmental outcomes. There's a lot of data out there looking at term babies and preterm babies and looking at MRIs, both at term age and the preterm infants and also later on in childhood. And babies who were fed exclusive human milk had better neurodevelopmental outcomes, and that was evidenced with improved white matter structure and gray matter structure on MRIs. And then they also did IQ tests and other Bayley's scores, and that also was shown to be improved in babies who were given exclusive human milk. And then overall metabolic dysfunction is reduced when we give human milk because, again, it's so much better tolerated than milk than formula for preterm babies whose overall body is very premature and they're lacking a lot of the metabolic advantages that a term or infant would normally have. Other benefits are shortened time to key milestones. So again, they're going to be able to reach full feeds faster. Dr. Stewart mentioned this earlier, especially babies who are given OIT or oral immune therapy. And that's something that is the colostrum that moms produce right away. And we put little drops in the cheeks of our babies who are not able to orally feed. And what that does is not only boost the immune system as what is called oral immune therapy, but it also has been shown to benefit the GI tract in terms of giving the GI tract a boost and giving them factors to help the motility. So one of the factors in human milk called BDNF is actually a pro-motility agent, and so that's contained in the colostrum, and so that's going to help those little elbows or VLBW infants reach full feeds faster because it's going to promote peristalsis. I think we all know our babies have a lot of dysmotility. And so again, giving an exclusive human milk diet can be beneficial to promote motility and therefore improve the tolerance and reach full feeds faster. And as Dr. Stewart mentioned as well, this would reduce the need for parenteral nutrition, which we know long-term parenteral nutrition can have effects on the liver most specifically, but it's also not optimal. Also, it has to be given through a central line. So if we can get those lines out sooner, we're going to decrease our CLABSI rates and decrease any other associated central line issues. And then we would hope that if they reached full feeds faster, their central lines are out, they're also going to be more likely to be able to start orally feeding sooner and potentially meet their milestones for getting home sooner. And so an earlier hospital discharge benefits not only the families, but also the hospital in terms of decreased cost. So this all sounds amazing, and it would be great if everyone had access to it, but there are a lot of barriers for many institutions to have access to an exclusive human milk diet. I think cost is a huge one that a lot of hospitals are looking into because maintaining an exclusive human milk diet can be costly upfront. I think the big thing to look at is what are you saving on the other end. So if they're able to reach their full enteral feeds faster, that means less central lines, less risk of central line associated bloodstream infections. They're also potentially getting discharged sooner, which means that that's a decreased length of stay. So that also saves the hospital money. And the big one too is if we have decreased complications like necrotizing enterocolitis, that is a huge cost for each of these babies if they ended up getting neck. And so if you're able to minimize that and decrease the risk, you're saving a lot of money there. Access is huge. So depending on where you are in this country, you may or may not be close to either a human milk bank or a place where you can get donated human milk. And so that can be a challenge as well. And whether or not your hospital has protocols to even access the human milk if it is available near your institution. So trying to develop protocols and things that can be utilized to help ensure equal access across our country so that all babies in any NICU have access. There's insurance coverage issues, and there's a slide later on where we can look at the United States and go over a little bit of that. And then overall, lack of education and awareness across our country and in our NICUs about the importance of exclusive human milk diets for these infants and what the benefits are. So this is the slide I was just mentioning about insurance coverage. So you can see this was taken from the paper, this map, and you can see that there are different coverages across the United States, and different states have different legislative requirements for insurances to cover access to human milk. And so you see we still have a lot of work to do to try to make this accessible across the country and in every state so that all preterm infants can really be given the best source of nutrition and the best start in life. So what the recommendations from this paper were is we want to educate moms early in pregnancy about breastfeeding and providing mother's own milk. And this really starts during the early phases of pregnancy. You want to ask the families what their feeding plans are, if they have any comorbidities that put them at risk for developing or for delivering preterm, something like preeclampsia, diabetes, any other issue that may cause them to potentially deliver preterm, you want to start that conversation about how important it is to provide breast milk for their baby that potentially is preterm, and look at some of those outcomes with the family so that they have a good understanding and can prepare early. We know it's great in term infants, and of course the AAP and the WHO are all about breast milk and providing exclusive breast milk for the first 6 months of life. But the AAP also has a statement about preterm infants and the importance of human milk in that population. So making sure that our families are aware of this important feeding plan, and then giving them the tools and resources that they need to be able to carry that out. So again, from a lactation perspective, if you can offer lactation education prenatally so that they can have an expectation about what's to come, that also is really helpful. And then educating our care teams, our administrators and policymakers, why is exclusive human milk so important in this population? And why is it beneficial to pay for this human milk? What is the benefit to not only the hospital, but also society in general for these babies to have human milk so that they can be the best, they can have the best outcomes possible. And then we would always encourage everyone to be contacting their different senators, congressmen, legislators, to be able to fight for human milk for all of our infants so that every infant has access to the best source of nutrition. So just in conclusion, I hope Dr. Stewart and I have impressed upon you guys that really feeding an exclusive human milk diet is associated with fewer complications. So most specifically, necrotizing enterocolitis. But I mentioned ROP, late onset sepsis, BPD is just a few other things that can be helped with an exclusive human milk diet. Also lower mortality, and then improved long-term neurodevelopmental outcomes, which I think is a really important part of all of this, to not forget that not only do they leave our NICU sooner, but they have better lifelong capabilities after they leave the NICU. So improved IQ, less neurodevelopmental issues later on, and those are certainly some of our goals in caring for these infants. It's not universally adopted yet, as you saw from that map. There's still a huge number of states that don't provide any access or support for exclusive human milk diets in our preterm infants. So we really need to do a better job in our society of gaining access for all of our infants and making sure that there's no systematic barriers for anyone to access that. And then again, improving awareness and policies and making sure that families are advocating for their babies and advocating to get access to exclusive human milk.
Excellent. Well, thank you, Dr. Tauber and Dr. Stewart, for that brief overview. We have saved a lot of time at the end for some questions, and we've gotten some in here, and so I'm going to pull them up. And let me read you this first question. I'm going to stop sharing my screen so everybody can see the two of you nice and big. Do you find that the benefits of exclusive human milk diet with fortifiers from human milk differ significantly from donor and maternal milk fortified with bovine fortifier? I know most data is looking at exclusive human milk diet versus formula diet. I'm just wondering if the benefits are more middle of the road with mom's milk and bovine fortifier or closer to exclusive human milk.
Well, there are multiple publications with the use of an exclusive human milk-based fortifier that shows that it's advantageous, particularly in the ELBWs, the extremely low birth weight babies. So if you give even a bovine fortifier, I think it starts an inflammatory cascade in the intestines of the preterm infant. And then this can lead to dysbiosis, which is an imbalance between favorable and unfavorable bacteria. I think there's sufficient amount of literature out there that supports the use of an exclusive human milk-based fortifier. Kate?
Yeah, I agree with all that you're saying, and I think in our own institution we've definitely seen an improvement since we switched over to exclusive human milk for any premature baby born less than 32 weeks. We do give exclusive human milk, and we've found that they do reach full feeds faster. Our central line use has dramatically decreased, and they just tolerate things better. And again, we always get questions about fortification, and growth is a big one that people always get concerned about. Well, they won't grow as well. And I think the take-home message is you don't be afraid of the calories, because there's a lot of times where people try to compare a bovine formula of 24 cal to a human milk based 24 cal, and those aren't the same. And we know from the literature and from our own institution here that we need to go a little bit higher on our calories. So as long as you follow the baby and you increase their calories as needed, so we're often at 28 cal feeds compared to before we used exclusive human milk 24 cal feeds. You can still have them have the appropriate growth and do great. And we have seen less necrotizing enterocolitis, particularly surgical neck, in our institution. So we have found that not using bovine fortifiers until the babies are past 34 weeks has been advantageous for us.
Yeah, we also only start with +6 fortifier because we found that the babies did not grow with +4. So that's been one of the things that our neonatal nutritionists really promote is that we start with +6, but as you alluded to, Kate, oftentimes we end up with at least 28 cows, or often end up with 28 cow formula. So.
And the thing to remember too is the osmolality or osmolarity of the formula is very different than the human milk fortified feeds. And so we also know that that's better tolerated. So even though you're at 28 cal or sometimes 30 cal exclusive human milk feeds, the osmolarity of those feeds is still on proportion or less than feeds with formula. And so again, another reason why these babies probably tolerate that nutrition and have better absorption and decrease inflammation in the GI system. So again, just other thoughts on why this nutrition is best.
Excellent. Well, we're getting a lot of questions in, so this is great. Can you explain about how mother's own milk improves microbiome?
So the microbiome basically it depends on establishing a favorable microbiome, depends on many factors, certainly the mode of delivery, the early nutrition, as well as the environment. And then there's epigenetic factors on that too, which influence the eventual outcome. But it gives the bacteria that are more favorable, bifidobacterium, and less of the harmful bacteria. So you get a very favorable microbiome and less of the more pathogenic bacteria. There have been many studies about the microbiome and how that's related to the development of NEC. Kate?
I was just going to add the HMOs are also a huge influence on the microbiome. So HMOs are human milk oligosaccharides, and those are produced, they're unique to breast milk. And so has a huge influence on the microbiome of the baby. And every mom's milk is made specifically for her baby. So again, you can give donor milk, they're just not going to have the same, makeup. And so that's why we have to really encourage moms to produce their own milk, because they're just genetically made for their own baby to make a microbiome that is, meant for that breast milk. And then again, the immune factors, the antioxidants, the growth factors, and then the HMOs are all going to be important in promoting a healthy microbiome.
Great. Another question here. Do you feel that babies on an exclusive human milk diet have better head and length growth, even with perhaps the same or less weight gain?
We track all of that weekly. I think that as long as you are providing the nutrition that the baby requires, so again, every baby is going to grow at different times and have different needs depending on their their morbidities, that this lung disease, things like that. We like our babies long and lean. I think that's what you're trying to promote, so that you decrease the risk for metabolic syndromes later on and insulin resistance and cardiovascular complications. So we do address all of that every week in our rounds, and we have found that they are adequate. They are growing appropriately and very symmetric, and so that's what our goals are.
Yeah, and as Kate mentioned earlier, so the MRI studies have shown improved both white and gray matter, and certainly breast milk has more sialic acid, which is a nutrient for brain growth. So, and we do monitor brain growth on a weekly basis, along with the somatic length growth as well.
Okay. I'm going to try to get to all these questions. What are your recommendations for soon-to-be discharged infants from the NICU? If the mother is not producing an adequate volume for the infant, do you recommend switching to formula prior to discharge?
So we do that. I mean, most babies, especially very low birth weight or extremely low birth weight infants, are going to need some type of fortification for the first 4 to 6 months of their life. Again, just because that's a period of rapid brain growth, and you want to make sure that you're giving enough protein. And then again, for their bones, so you want to make sure that they're going to get enough calcium and phosphorus. Most of those infants missed out on the last trimester, and that's when the majority of the calcium and phosphorus are deposited into the bones. And so you really want to make sure that they have all of those nutrients coming together in those first couple months. So there's been some papers, over the years. Dr. Damkin's a very, very big proponent on making sure that we continue a lot of that fortification for several months. And so there's often times that most of our babies don't go home on just breast milk alone because it just doesn't have enough of those extra nutrients they need. And so if moms aren't producing enough, but they still intend to actually breastfeed, then we try to figure out what the baby's needs are and then promote so many breastfeeds a day, and then the other ones can be fortified formula. And we do start that before they go home, because again, if a baby's only been getting exclusive human milk and then they're switched right away to a bovine product, you don't want them to have any intolerance and then have to have the families and the pediatrician who's just meeting this infant to try to navigate those difficulties on their own. So it would be ideal to start that transition in the NICU so that you can ensure that the baby's growing well, you determine what calories they need so that they're set up for success once they go home.
And we do a very similar thing. We have 3 neonatal nutritionists in our level 4 NICU, and we start with at least two bottles of formula, 22 cal, which has got extra calcium and phosphorus, et cetera, and make sure that they're growing and tolerating that. And then some of the babies we may send home 24 cal, a couple feeds a day, and very seldom do we do above 24.
Okay. All right. So let me ask a couple more questions. We've gotten a question about CHD babies in here. So who else, I guess, besides preterm infants could potentially benefit from an exclusively human milk diet?
So there's some emerging literature on infants with gastroschisis or omphalocele or atresia, so some of the GI kiddos, and then also congenital heart disease is another one that more of the cardiac ICUs are using exclusive human milk. I know in our institution, our GI kiddos come to our NICU, and so we have adopted an exclusive human milk for the short term in these infants because we do find that they tolerate it much better. You know that their GI system is dysfunctional, depending on if they've had a surgery like an atresia where they had to get reanastomosed. You know, their microbiome is not normal, and so giving an exclusive human milk diet can help repair the intestine. There's a lot of growth factors, as I mentioned, in human milk, and so it can help repair the intestinal lining, can help promote a good microbiome, and also those growth factors can help grow the intestine and improve peristalsis. So that's been really helpful for our infants, and we're looking at our data now in pre implementation of human milk diets for these infants and post. And so hopefully we'll have some data out there soon. And then for our congenital heart disease, there's definitely some emerging data on how important it is. Dr. Blanco published a paper not too long ago looking at a bunch of different institutions who used exclusive human milk in cardiac infants, and that was very promising. We've looked at data in our own institution and found that those babies that got exclusive human milk had significant decreased length of stay compared to those with formula, and also reached full feed. So there was less starts and stops and concerns for neck or necrotizing enterocolitis. So we are in the process of adopting exclusive human milk for our cardiac infants. Dan, do you do something similar?
Yes, absolutely. As you've alluded to, the gastroschisis studies have been very convincing about use of exclusive human milk diets, and I think it's going to be very appropriate for the ileal atresias and duodenal atresias, et cetera. Although there's not published studies out there to my knowledge. And then our heart babies, one of the caveats about our heart babies that we do a little differently is that when we start them on feeds, we just let them take orally. We don't NG feed them so that they can basically demonstrate tolerance. Yeah.
Okay. I've gotten a couple of questions in here that have to do maybe a little bit more about the family. So I'm going to ask these. Can you name a couple of supports which could help increase the amount of mother's own milk that is available to babies?
I I can take this one. I do a lot of quality improvement in our institution to try to promote lactation in our parents in the NICU. So I think, we all probably suffer from not enough lactation support in our NICUs, and we don't have a dedicated lactation consultant in our unit, which is, always hard when we're a 60-bed unit. And so we have a lot of parents that would benefit from additional support. But we've done a couple of things that has been helpful. We've gotten a group of our NICU nurses to become certified lactation counselors. And so they're a group that can be helpful. So if there is a mom who is having trouble, they can meet with them in the NICU in real time. So there's usually one of those on during every shift. And so that can be a helpful support system for families. I've also created a project called Latch, or Lactation Advocacy through Continuous Help, and it's a group of medical students that are certified lactation counselors, and they come in and meet with families, all families who have a baby less than 32 weeks gestation at birth, enroll them in a voluntary program, and then they meet with them at least weekly, if not more frequently, throughout the entire NICU stay, because sometimes we see these families start breastfeeding or pumping, and then they have challenges, and there's just not that same support once they've been discharged from the hospital and they're home and life kind of gets at them. And so this is a way that they can reach out to someone, text message, phone call, in person, whatever means of communication that work best for them. And then these med students meet with them throughout the entire NICU stay. And so we have found that that's improved the breastfeeding rates throughout the entire stay, but most importantly at discharge. More of our families that are enrolled in this program have gone home with breastfeeding their babies. So that's just a couple opportunities for people to potentially implement in their own institutions.
All right. A lot more questions here. I have two that are pretty similar, so I think I'm going to combine these. They're both about this 34-week turning point, which I think Dr. Tauber, you mentioned. If having to transition from a human milk-based fortifier to a bovine-based fortifier, let's say due to cost, is 34 weeks the turning point, or do you also wait until a certain weight has been achieved?
That's a great question with the weight. So, we kind of use the 34 weeks as a just a point in the baby's milestones to consider transitioning off of exclusive human milk. There definitely are institutions that do it sooner. And again, I think a lot of that is cost and not as much data saying that 32 weeks is any different than 34 weeks. So there's a range of gestational ages that different institutions are transitioning off exclusive human milk. But I think the weight is also important. So if you have these small for gestational age babies or very growth restricted babies, those babies are ones that are at much higher risk for necrotizing enterocolitis and feeding intolerance. And so depending on how growth restricted, we may wait a little bit longer to transition those babies, not necessarily to get to a certain weight, but just so that they can have more of the benefit of the exclusive human milk before we transition them. But routinely for, not the sort of those populations, those specific populations, we do transition, and we do it over a 4-day period. So it's not just one day they're on this and then the next day they're on formula. We do it slowly over 4 days. Again, just watching for tolerance and making sure that babies are doing okay with the bovine fortification.
And we do exactly the same. We use 34 weeks as our marker to begin the transition, and it's a transition over several days, introducing two formula products that out of the 8 feeds a day, and then try to get them transitioned over a period of 4 or 5 days. And then we used to use 33 weeks, but unfortunately we had a few at least anecdotally, we had it seemed like an increased instance of NEC. So now we have moved that target date back to 34 weeks gestational age, and we've seen less indications that there's been development of neck with that transition.
Okay, great. We have about 5 minutes left, and I hope we have time to get to all of these questions. Someone's asking about basically the affordability. So is human milk fortifier just simply more affordable? Some of our NICU babies are covered by Medicaid. How do we get coverage for private insurance and Medicaid as well? So I think they're essentially saying uh, is cost is a factor, obviously, which both of you spoke to earlier, but anything additional you'd want to add to that?
Dan, do you want to comment? I can comment.
Yeah, well, I mean, it's certainly an issue, but there's been multiple studies, including the Swanson study, which I was a co-author on, where we looked at the even though the cost of using donor milk and donor milk fortifier, breast milk, human milk breast fortifier, it certainly is more cost effective when you look at the long-term sequelae. When you talk about surgical NEC, and all the other comorbidities that we've talked about, and length of stay, and also mortality, and also mortality. So when you throw all those issues in, it really is cost effective. And then certainly the L8 and Assad study also showed it to be cost effective. So there's multiple studies out there showing that the cost is certainly ameliorated by the cost savings when you prevent these comorbidities.
And I just to point out, based on the question that was asked, so a lot of times the insurance is not covering these human milk fortifiers, human milk based fortifiers. But when we're saying the cost is effective, it's because the hospital, yes, they pay for it upfront, but they're reaping the benefits of the cost by the benefits of shorter length of stay, decrease infection, decrease of NEC. So it would be amazing if insurance companies could cover all of this, and hopefully at some point they will. I know there's a lot of people trying to advocate for that, but certainly, the more of us that can reach out to our, legislators and really try to push them to push insurance companies to cover it, the better. But I think, the Medicaid and Medicaid does cover donor milk, but not the fortifiers yet. But hopefully that's to come.
In the state of Kentucky, from the Louisville area, we had a legislator who had a set of 26-week twins, and he insisted that the baby get the human milk, fortifier, as well as donor human milk. And he actually got legislation passed in the state of Kentucky where the private insurance have to cover for those products.
Yeah, that's Representative Morgan McGarvey. I've had the chance to meet him, and he has introduced some similar federal legislation. Although, as we know, Congress is just a bit of a stalemate at the moment. Okay, so last question, and I think it's a really good one that we wrap up on. And it's back to talking about parents. So, how do parents know what kind of nutrition their baby is receiving in the NICU, especially if they're an extremely low birth weight or very low birth weight baby? And is more education needed among parents to understand the difference between, a mostly human milk diet and an exclusive human milk diet?
So we do a lot of education if we have the time to be able to meet with the families prenatally, so they're not like coming in and delivering right away. They'll get a NICU consult, and so we all educate the families at that time. We have information sheets we leave with them so that they can process the information at a slower pace once we leave the room. But we really do promote an exclusive human milk diet. We talk about the risks, we talk about the benefits, and so hopefully they're leaving, that consult with some education and information. And then there's a lot of resources that they can look up online. We also try to do that in our prenatal, like outpatient visits and in the OB clinics to try to start that around 28 weeks with our families, just to talk about the importance of exclusive human milk and the feeding plans. And then when when parents are there, they have to sign consent in our institution to allow us to give their babies donor human milk and a human milk based fortifier. And so, usually at that time with the consent process, we talk, and then during rounds, we talk about how their lactation process is going, what kind of help they need. And that way they're educated on that process and what their baby's getting. And then when it's around 33 weeks, we start talking to them about the transition at 34 weeks, if that is the goal for that baby.
And just like Kate, certainly in our prenatal consults, we emphasize the mother's own milk and the value of having the mother's own milk, and that we, even the benefits of the human-based milk fortifier. Certainly, we bring all that up prenatally. I think the opportunity is open, though, to work more with the perinatologists and the obstetricians to let them also be a proponent for these products, and also our state legislatures. I think your local Academy of Pediatrics, like the Kentucky AAP, we're very aggressive in trying to get the legislatures to be supportive of, like Morgan McGarvey's a national bill to get this at the national level. So I think we could do more work at our level A advocacy at the AAP level, as well as with our perinatal and obstetrical community.
Yes. Well, as a coalition whose main focus is on advocacy, I would agree that advocacy is very important. So, Dr. Stewart and Dr. Tauber, thank you so much for this very informative presentation. I can tell by the amount of questions we got, there's definitely a thirst for information and knowledge. So I feel that this was extremely valuable to give today. So for everybody joining, we will be sending a follow-up email about today's webinar with more information.